So it's my pleasure to introduce our next speaker, Dipak KALRA, and we already heard about smartphones, about smart watches. We could speak also about, obviously, electronic health record, and I'm sure you will do it. So Dipak is certainly in Europe one of the best specialists of all the questions related to mobile health. He is a professor of health informatics at University College London. And above all, is the president of the European Institute for Innovation through Health Data. And I can tell you that in many European bodies, Dipak is really the expert that people use to try to anticipate what will be the future. And actually, the title of his talk, I think, is quite promising. Mobile health, will every patient become a doctor? Dipak, thank you for being with us.
Good morning, thank you very much. And I'm sorry that I have to speak to you in English. My French is just not good enough for this scientific level of communication. I apologize for that. So Michel gave me a very difficult topic, and he also explained to me that this séance is also thinking fresh about the future of medical education and tomorrow's doctors. And so I'd like us to think a little bit about this topic from the perspective of what will tomorrow's patient look like and what are the implications then for tomorrow's doctor. And I would like to begin by reminding you really of the context in which we are all operating in healthcare, but where tomorrow's doctors really need to be well prepared. That we are in a situation where public spending on health is falling behind costs in most developed countries, partly because of historic economic crises, as you well know, but also because of rising demand. An aging society, increasing problems of multi-morbidity, and challenges of delivering good public health services. Tomorrow's doctors will be monitored to look at the responsiveness to the needs of populations and also equality and equity of care. So these are challenges for which, as a medical student, I was never even given the thought that these issues might face medicine today. So I am absolutely not prepared for this. Let's think for tomorrow's doctors what we have to consider. Now let's look at the opposite side of the story, that where historically medical education focused on the what I would call the sexy diseases, the real burdens of healthcare now are with chronic disease. This is where we have to look and sharpen what medicine delivers. But there is good news sitting in this space. If we can leverage the advantage of health informatics solutions, health IT, such as telemedicine, we can help ameliorate some of those issues. So the first of these 3 bullet points is talking about a reduction in the consumption of healthcare. The second one is about reducing costs. But what excites me is the third bullet point. Telemedicine is not a tool to save money. It's a tool to save lives. We can improve clinical outcomes by making better use of health IT. And that is the starting mental paradigm we need to educate doctors about. This is, I love this slide. I've not used it for a few years, but it's actually a really old slide. Look at the bottom, 1997. And this is really describing, sadly still, how we tend to think of medicine. There is a promotion towards the super specialty in resources. And I apologize to many of you in this room because I guess many of you are super specialists. But in fact, the history has been that we push money and priority and patients up the triangle. But what's most important about this triangle is the bottom base. This is the patient before they enter primary care. This is the person at home who medicine has historically ignored. In information age medicine, we see a real transformation. We see that a large amount of that previously ignored grey zone is people delivering self-care, collaborating with friends and family and self-health networks. But look at the left-hand side of this bottom triangle. Professionals as facilitators, professionals as partners, and only sometimes acting as authorities. So this is really about changing the relationship between healthcare professionals, between doctors and patients. And so we cannot look at the introduction of novel technologies without thinking about the impact on relationships. And it's really about, can we train doctors and can we train ourselves, forgive me also challenging you, can we train ourselves to be partners in the future relationship with patients? For example, can we set healthcare goals jointly with patients, using clever technologies to help the patient to travel on their own pathway towards health improvement or disease management in a relationship that is partnering decision-making? Can we use advanced reasoning, advanced technologies, I won't say AI because this was not an AI slide, but about predictive modeling, to help patients to understand where is their lifestyle, where is their current disease profile, projecting the future state of their organs? Can we help patients to understand where they are heading and what they can do to change their future prognosis? I love this slide. This is a little diagram. It's actually a PhD student result, looking at, in summary, what is going to kill you and when. But what's nice, and you don't see it on the slide, is that you can then play with your risk factors computationally and regenerate this graph. And so rather than saying to every person, you must do this much exercise, eat this many portions of fruit and vegetable, we can start to personalize people's goals and give them something rather individualized about how they can move forward in their lives. And that means we need to really rethink, what is the professional? This slide describes a spectrum of where patients might be. And on the bottom in green and red, you see the traditional positioning of healthcare, the traditional positioning of the doctor. And I think this is the diagram we have to change. The doctor of tomorrow has to be right through into a co-production space where they are working with their patients to improve health, manage diseases better. And remember, a patient will not be at one point on this chart. In multimorbidity scenarios, they will have several points on this chart because different conditions will be at different points. And just because you have one serious disease, that doesn't mean you ignore prevention of the other 199 diseases you don't have. So we need to support patients on this spectrum. And there are lovely technologies coming forward. We are at a time of exciting ICT innovation. And I decided I will not fill this presentation with toys. So this is the main toy slide. The reason is I want to really challenge us in discussion after my talk about relationships, about what does tomorrow's doctor have to be like? What do we in today's medicine have to be like in response to these exciting innovations? That's a futuristic slide. This is a current slide. This is an infographic from the European Commission. And you can't read all the numbers, but any of the numbers that are a little bit large, what you can see is they're big numbers. Forget the detail on this slide. Mobile health is not a dream. It is an avalanche already tumbling over us. And we are already finding ourselves poorly prepared to support patients in this journey of playing with toys or using smartness to help empower themselves and help change the relationship with us. We need to remember, some of you will remember how we used to tell patients to monitor their blood sugar with passing urine in a toilet and little tablets in a tube and writing in a book. I mean, isn't it exciting how today it's so easy? Patients are wearing things that they can hardly see. And they don't bring a book to the clinic to give to the doctor, who quickly looks at it. Really, honestly, did you ever look at those books, if you remember those days? How many decisions were influenced by that book? Almost none. You spoke to the patient, you examined the patient, and you politely looked at the book, but you didn't really do much with all that data. So let's turn that around. This is about the patient deciding, I'm going to eat what I want to eat, when I want to eat it. And the technologies and the smart, clever insulin syringes I can carry like a pen in my coat, they will sort out the disease. The disease does not dominate me. Christmas lunch dominates me. And the disease has to look after itself with tools and technologies. The European Commission has a very nice green paper on N-Health, which is now getting a little bit old, and I suspect that you know that these are, if you like, today's vision of where we are going. So I won't speak to all of these points, but I guess you can read them pretty quickly. Mainly what we're looking at is using smart technologies today to help people to self-manage diseases, to detect escalations in their disease, detect complications, help them also with self-motivation in prevention, hopefully reducing things like hospitalization, and importantly, changing the role of the patient from a passive piece of biology to an active player in their own health. And then if we have that opportunity, we know that an engaged population will help reduce the pressure on healthcare services, but also will help to generate huge volumes of data that add to our learning and our understanding of disease and treatment. So we see this as a really exciting opportunity, and it is increasingly going to be convenient to the patient. So everything I've showed you up to now is today or even yesterday's story. Where are we going? We are going to a stage where people can start to treat healthcare technologies as a commodity. They can go into a shop and pick up a blood test, a little chip with a tiny prick on it that captures a drop of blood and provides them on their mobile phone with real-time analysis, which they can then choose to send to their electronic health record, either for an algorithm to be monitoring or for a healthcare professional to be looking. I don't think tomorrow's healthcare professionals will spend their time staring at a screen waiting for these signals to arrive. There will be escalation algorithms that ignore the 99 out of 100 which are within range and only flash to the clinician the 1%, the 1 in 1,000 readings that are out of range that might need a decision. Look what's really nice about this last picture. The coffee cup. Where is this taking place? Is the patient carrying a form, going to a hospital, taking a morning off work to go and have their blood test? No. This is tomorrow, and it's almost today. The technology exists. It's just a bit expensive, it's not at scale, but it's getting there. And health is not just about managing the disease. It's about using apps, using technologies. This is about barcode scanning to be informed about the the health impact for that patient on certain foods while they're shopping in the supermarket. What do you put in your basket is what this app is telling you. What is good for your health to put in your basket. And it's not just health. We see now ecosystems starting to emerge in which many dimensions of a person's life can be interfaced through apps and smart technologies so that we can be more holistic in how we prevent disease and help patients to cope with illness. So this is where we're going in the future. This is the exciting part. But I'd like to step even forward one more time with my last couple of slides. Well, actually, the last but one slide. So we have an enormous volume of potentially wearable devices and other things. And we are going to see this avalanche of data taking place. I'm going to relax my voice now for a few seconds while you watch the screen. This is really the concept of the digital patient. And all of these things are not dreams. They're all realities. This is the universe of the digital patient already. And the question we have to ask ourselves is, are we ready for the digital patient? And are our students coming forward ready for the digital patient? And are we ready to harness the learning opportunities from all of the many sources of big data that are becoming at our disposal? There are huge opportunities from all of this. And the question really is, are we prepared? So I want to now move to my last slide. I hope I'm all right for time. But I'd like to take this last slide a little bit slowly, if I could. So here I really had to think about this talk and what would I see as the challenges for the future of training doctors. But I'd like to show you first the title of this slide has a word in brackets. Why does it have that word in bracket? Because if medical education hasn't changed since I was a boy, then most of what you learn about how to interact with patients, about professionalism, about the role of a doctor, are not things you learned in lectures. They were things you saw in practice among the seniors, and you copied and you learned from them. So I'm afraid the challenge of this slide, yes, it's what we want to teach students, but actually what do we have to do ourselves to demonstrate to our students what does tomorrow's professional look like? So this is why this is a tough slide. And the first point is not even about the patient. You know, all of you know, that modern medicine is multi-professional team-based. But we still do not see necessarily good peer-to-peer trust and collaboration models in our daily lives. If we do not demonstrate ourselves how we work across professionals, we cannot expect patients to trust a specialist nurse to help them with their disease, because they will always think the doctor's in charge. Why am I not seeing the doctor? Why am I seeing a piece of technology when I should be seeing the doctor? We have to start with that example. But then we have to consider some challenges facing the patient. Transparency. We cannot empower patients to help look after themselves if we are not willing to be truthful and to share with them their health information. There is still a tendency in the medical profession to give patients sound bites, little pieces of the truth. But we have to be willing to share much more openly if we're going to bring patients on board as partners. We have to be ready to empower them through education. So our role is not to tell them what to do. Our role is to teach them how they can work out what to do in different scenarios. We have to be willing to embrace remote monitoring and self-management. That means that our process of following up a patient is not, as I was told myself in clinic last week, we'll see you in 4 months. That is old-fashioned medicine. The modern way of tracking how patients are is a different approach. And that means we have to be ready to trust patient data. I have been developing electronic health record architectures and systems and requirements for over 30 years. And one of the biggest pushbacks I've had in my entire career from doctors about opening up the electronic health record to patients, not to view it, but to enter data, is I don't trust patient data. That is yesterday's thinking. We have to be ready to embrace trust in patient data. And of course, you know that technologies can help timestamp when things are written. They can confirm who put the data in. So there are additional trust opportunities with technology. But until we are ready to trust what patients give us, we can't partner with them and empower them. Let's be honest. It's not as if you trust everybody. How many times as a GP did I do a blood test, then refer the patient to hospital, and the consultant repeated the blood test? Because they didn't trust a GP requested lab result. So insulting. So we don't demonstrate trust either within our own peer community, but we have to learn to change that paradigm. Not only the data, but decision-making, shared decision-making. Now that can be uncomfortable because we start to see a tension between the professional aspirations for a patient and the patient's aspiration for themselves. I have a standing dialogue with a couple of colleagues about how we rank the success of cancer treatment units. One of the most important success factors for a cancer unit is survival rates. I mean, that's almost like a gold standard, isn't it? But you know, survival rates are about saying the most important goal for a patient is length of life. What if the patient's goal is quality of life and they're willing to compromise on length of life? Then it means they're actually going to damage your survival rates, but you're treating the patient better. And those are challenges for us as professionals. And finally, linking actually to the previous presentation, I'm sorry, I didn't understand all of the French, but you know, we are going to start using decision support to support patients. So we thought especially about decision support supporting professionals. I think that was the spirit of your talk. But decision support will support patients. And then what does the clinician become? The clinician becomes the mentor, the guide, the advice. Because the computer will give advice, the patient will have a feeling about what should happen. And in all of those areas of uncertainty, the healthcare professional, the doctor, remains the contact point. So we need to change our doctors from telling everybody what to do to empowering patients to manage a lot of their care themselves. I'm not talking about the diagnosis. I'm not talking about patients becoming their own diagnostician. But most of today's healthcare challenges are not in the diagnosis, except for rare diseases. They're in the long-term care. Long-term care, we need to change our game. Are we ready? Open for discussion. Thank you. So, Michelle, you did ask me to be a little bit controversial.
Yeah,
I have been sufficiently controversial.
I hope it will continue. But there is a question there.
Thank you for your beautiful talk. One thing that you haven't
Perhaps you can
addressed,
stand.
one thing that you haven't addressed is how healthcare is financed, and I think that there is going to be a big discussion with how politicians finance healthcare in order to implement this.
Well, I think that there are two different subtopics within that, because actually the business models of healthcare are an important topic to me as well. So one is the macro, which is how do we fund healthcare itself and the extent to which we operate insurance-based, fully taxpayers, or some hybrid models with even patients and other people contributing to care. But I'd like to turn to the bigger problem, which is the micro level. When we want to give a patient a device that costs money, let's say it costs €500 to give them some equipment that allows them to self-care. What I have seen in so many health systems across Europe is a problem with who pays the €500. Because for the hospital, who has been seeing the patient in clinics, this is a way of discharging the patient back to the community. So why should the hospital be paying? This is no longer going to be a hospital patient. The hospital doesn't want to pay €500. Let's go to the GP. The GP is thinking this is a hospital patient. You want me to pay €500 so that the patient can now become my healthcare responsibility and not yours. I won't do it. So what we see is a real problem within our existing micro business models of healthcare, that actually these patient-centric innovations don't have a clear funding stream. What I'm trying to do is to talk to health insurers, because they're the ones who eventually control the higher level budgets, and say to them, if you want to see stronger prevention, if you're willing to take a medium-term gain, instead of reimbursing things that occur in a 3-month period, a 6-month period, if you're willing to fund things that might have a return for you in 5 years' time, where a patient avoids complications because of better disease management, then as a healthcare payer, that's got to be your response. You have to change the reimbursement models for these actors. And that's the discussion I have. And interestingly, when I speak to what I call ministry-funded health systems, the answer usually is very negative. Why? Because the politician life cycle is too short. Sorry. When you speak to health insurers, like the German health, I'm going to give an example, German health insurers. I've not spoken to Belgium, so I apologize for that. But when I speak to the German health insurers, they say, yeah, that's fine. We insure people for decades. We don't mind if it takes 5 years. I remember having a discussion with a French health insurer, a not-for-profit health insurer, who told me, look, if it takes 80 years to deliver a benefit, I don't care. We insure whole families for generations. We're okay with that, which is, to me, really exciting. So maybe those insurance models have to show the way and demonstrate the cost-effectiveness of these tools, and then the politicians might take interest. But I don't have an answer to your question. I'm just describing how I'm trying to explore the topic.
First the question. En anglais ou en français, comme vous préférez.
Thank you very much for this insightful. Now, this is emerging in high-income countries, but the access to a number of technological devices is increasing dramatically in low and middle-income countries. And this raises a number of questions of how we could help, backing up local practitioners, but also in the availability of free and open source programs, and perhaps legal issues relating to privacy. So now in Europe we're so concerned with privacy, but this may not be the case elsewhere.
Well, those are very interesting questions. I had the privilege only a couple of weeks ago of giving a remote presentation into a workshop taking place that day in Estonia, but it was actually for how can developing countries establish e-health strategies, learning from those countries that have already made lots of mistakes to avoid repeating them. And I think that what we are seeing is that for some of those countries where there is a real shortage of expert health professionals, and sometimes in big geographical areas there are transportation issues around moving patients to the specialist. In fact, everything I've said is even more economically viable, because it allows you to deliver care into remote villages using satellite technologies to link people. And in fact, I was discussing with somebody only recently who's developing innovative mobile antennae So this is an ICT innovation, not actually targeting healthcare. They were targeting, ships and planes. And I said, well, I remember a project where somebody was looking to put a server on a bus, the village bus, that goes from the town, proximity to the hospital, where it could do some remote exchange of data. And then it would go to every village in quite a big area. And maybe the bus would have a Wi-Fi connection. And as the bus arrived in the village, everybody's devices would just automatically connect, upload, download data, and off the bus goes. If we're a bit clever, everything I've said is highly applicable to these areas. And of course, these are lower cost than having more specialists and setting up more hospitals and more clinics. So I do think it's viable. Privacy issues are of a hot topic in Europe right now. I've actually been exposed to a lot of GDPR workshops in the last few weeks. I was actually in a GDPR workshop only on Monday in Brussels here, hosted by FPA, the Pharma Industry Association. I think, though, we almost certainly can establish fairly robust privacy protection to European standards, and they will then be applicable globally. We think at the moment that developing countries are less concerned about privacy protection, and it's true that in some parts of the Middle East, I've discussed with colleagues that they are less concerned about privacy protection for citizens. It's true. But then there are countries like China that have made clear and signalled, and Japan has signalled the intention of going in the same direction as the GDPR. So I think, to be honest, if we can do a good job in Europe, we then have a globally marketable solution. So our companies in Europe have a strong chance of learning because of our GDPR. Sorry, I'm using the term GDPR. Does everybody know it?
Yes.
Okay, the General Data Protection Regulation, which is the newest European regulation on data protection, came into force in May this year and is causing a few pain points across the ICT sector and the health sector and the research sector. It's quite stringent, but at the same time it's setting up a high bar that I believe we can reach. And if we do, nobody else in the world will have a problem with European know-how.
Two questions, the last two questions. Please,
Well, I just want to start with an example of a patient that you probably know. It's your Prime Minister, Theresa May, who is, suffer from diabetes type 1. And as you have probably seen, she has this device, this sensor. And when people ask them who pays for that, she said, I pay it myself, because the NHS has no money to pay for all the patients who have suffered from diabetes. But just to give an example, to emphasize the fact that the reimbursement of the device is really a problem, even in the so-called developed countries. But I want also to go back to one of the points you mentioned in your presentation, and it's the importance of the patient. And for example, in Belgium, we have the system of patient education exists already from the 70s. And the health service reimburses now the nurses who provide education to the patients who suffer from diabetes, and so they are able to better know how to use the device. But you also mentioned that now that the doctors should become educators. And so I want also to give you another example of what is called therapeutic education. Is the example of Geneva, where one of the diabetologists there in this hospital opened a department in the hospital that was called Department of Therapeutic Education.
Wow.
So the question is, did you think about the way the whole system should change to go into the system of empower the patient in their service, in their self-monitoring and self-management?
Well, these are very good questions. Let me go to the education one first. I think that it wasn't my intention that every doctor now starts running evening classes for their patients. But you know that very often in clinical teams, the doctor is still seen as the senior member of the multi-professional team, the leader. And so I believe that by example, the doctor has to show that he or she adopts an educational approach. That when you are with patients, don't tell them what to do, explain the reasoning. So it's small, it's a spirit within your style with your patients. But of course, the bulk education should be done by people who are trained in education and training. I fully agree. But there's a spirit of empowerment and empowerment through education that has to enter the doctor as well. If the doctor ignores that as a paradigm and just outsources education to some other person, I'm afraid then we go back to how medicine was when I was in my junior days, where we thought seeing a dietitian was for the doctor a tick box. Patient has a disease that has a dietary component, refer to dietitian, change that. I've done it. I can ignore that aspect of the patient now. I'm sorry, that's how I was trained. Maybe you weren't trained that way. But we need to change that. I think that's very important.
Thank you very much. Je sais qu'il y a encore des questions. Je propose qu'on les garde pour le débat qui suivra, l'orateur suivant, qui va être introduit par Gustave Molène. Thank you very much again, Dipak.
Thank you.